All right. Well, good morning, everybody. And my name is David Mineta. I'm the president and CEO of Momentum for Health. We are a behavioral health, community-based behavioral health agency here in Santa Clara County. I want to first thank San José State University for this annual visionary event, Transforming Communities, a Movement to Racial Justice. And it is an honor for Momentum for Health to be a participant and presenter during this, I think, 3 weeks or 2 weeks of events. And I'd also like to actually thank and recognize, we have a couple board members from Momentum On. And a lot of our efforts in the DEI and racial justice, social equity space is part of our strategic plan that was endorsed and approved by our board. So a lot of the work we are doing from top to bottom in Momentum for Health is part of our makeup. So before I turn it over to Stacy and to the rest of the staff, I just wanted to, at the top, kind of frame what this discussion is about. And the title of the presentation is The Intersection of Mental Health and Race. And if nothing else that the pandemic has showed us is that health disparities are in very, very stark evidence across the country. And what we can see also is that in the health disparity gap is that in behavioral health, we see that as well. That communities historically that have suffered in this health disparity gap, that the gap has widened even further in the pandemic. Many communities of color, low-income communities, have particularly felt the brunt of the pandemic. We wanted to actually focus on the behavioral health side of the house. And both from a practice standpoint, also from what our staff and management team see, we wanted to bring that to the fore in this discussion. I would like to just end by saying, after the George Floyd murder, Breonna Taylor, after all these tragedies across the country, I know for many agencies and many organizations, there was a moment where, in the life of our agencies, many just said, this is enough, and somehow we have to figure out a way to move out on race equity and become institutions in our community that are anti-racist. And we need to look at our own practices. We need to look at how we do our business. And I'm proud to say that Momentum has done that for the last 2 years and will continue. It's a part of our fabric. And as you will see in our discussion today, I'm very proud of our team in place and folks that don't know it yet, but will be joining Momentum as well to advance this agenda. So with that, I will turn it over to our DEI director, and the leader of our internal movement around race equity and diversity, equity, inclusion, Dr. Stacy Richardson. Thank you, Stacy.
Thank you, Dave, and welcome everyone. I'm excited to help share and be involved with this panel. And with all those wonderful words from Dave, I want to just be able to introduce who our panelists are and briefly segue, talk about what Momentum does, and then we're going to start the questions in terms of hearing their feedback, especially as it relates to access, stigma, and criminal justice involvement. So this morning, our panelists, and in no particular order, y'all, are Diana Madrona, who's our outpatient program manager for our Eastside programs, Sarah Morales, who's our program manager for our addiction treatment services programs, Susie Cardoza, who's our program manager for our full service partnership adult program, Adrian Juarez, who's our associate director for medical services, Quentin Brooks, who's our assistant manager for our subacute residential treatment, SART, Karee Parvin, who's our associate director for Crossroads. And of course, you've met our esteemed CEO and president, Dave Mineta. And a little bit about Momentum, we provide behavioral health services, as he mentions, for mental health, addictions. Folks are able to get medical service through our psychiatrists, our STEAM group with nurses and all, and we have a continuum of care within Santa Clara County. We have a very large footprint, from Palo Alto to South San Jose. And we include employment services, and we really do invest in the health of our community. So one of the ways to really kind of show and demonstrate that is also to talk about what some of the challenges of our community. So I'm going to start this by posing questions to our panel. And they're each going to take a moment to respond. And if we don't already have some questions queued up at the end, we will go through those at the end of the event, or give you a chance to ask them in chat. So the first question, and this will go to Susie. There's historically a lack of trust among minorities towards medical and health providers. For a number of valid reasons. And what do you find is the biggest challenge around access to care, and in terms of what the clients identify, especially minorities? And can you give us an example?
Sure, of course. Good morning, everyone. My name is Susie, as Stacey mentioned. And to answer your question, well, while COVID has created an increased level of demand for mental health and addiction services among youth, adolescents, young adults, and further, according to the U.S. Department of Health and Human Services, both Black and Latino individuals have significantly less access to mental health services. And according to an annual review titled Sociology, Race, and Trust, distrust towards the American medical and behavioral health system is connected to individual experiences of racism or fear due to the lack of knowledge about it as well. So cost maneuvering the county call center, language accessibility, certain insecurities such as housing, transportation, technology, perhaps a limited social support as well can affect an individual's access to care. So I wanted to share a little bit of a case example of someone that I met just to kind of drive the point. I did an intake for a 26-year-old Colombian female. She immigrated to the US about 2 months ago prior to having received her referral. She was referred through Emergency Psychiatric Services, EPS, while placed on a hold for danger to self, quote, bizarre behaviors, experiencing auditory hallucinations, positive for meth, suicide ideation, paranoia, and reported being a survivor of sexual assault. She had just moved here from Colombia 2 months ago, to keep in mind, and was already facing all these sets of challenges. The client was also monolingual Spanish speaking. So according to the National Association for Mental Health Illness, NAMI, language barriers can make communicating with different providers incredibly difficult or even just seemingly impossible, particularly when a person is seeking counseling for sensitive and uniquely personal issues. These topics can be difficult for anyone to put into words, but it's especially difficult for those who may not speak the same language as a potential provider. So she expressed to me having no understanding of the mental health system in the US at all, having not spoken about her symptoms to any family or friends because it would, quote, be perceived as crazy. Though I knew via referral that she was experiencing certain symptoms, it was hard for her to even come up with the words to explain it during the intake process because she just expressed that this language was incredibly foreign for her. So discussions about behavioral health concerns were not the norm of conversation culturally and or through language, even a shared language that we both shared. the intake was completed in Spanish. The stress of accumulated to a new culture by herself only exacerbated these symptoms. And it was incredibly humbling to be the first person who she shared her symptoms with, but also disheartening at the same time to know that individuals of color face these kinds of barriers when attempting to access care. And to further highlight some of these access issues, I'd like to just briefly highlight some of the challenges that we see as providers. I'm a clinician as well as a manager at the FSP program. So these are some of the things that I'm seeing as I'm running into supporting clients. So initially, to be connected to services in the Santa Clara County for a community-based organization like Momentum, all referrals first start through the county call center. This requires an individual to just have the motivation to call, right? And there might be long wait times to even begin with. And if someone is monolingual English, non-English speaking, there might be fear to even pick up the phone to even access that first step to care. Additionally, there's also the assumption that an individual is going to have an access to a cell phone or a phone in general, which is an additional barrier, excuse me, because many of our clients don't have access to a phone or someone who has a phone as well. Now adding the additional barrier of, excuse me, of having a diagnosis such as schizoaffective disorder, now there's the barrier of having to call the call center with active auditory hallucinations, as well as paranoia that maybe the operator on the other line is part of the FBI who's going to expose your information, along with a language barrier. Other things may include not having medical insurance, which luckily for us, fortunately, Momentum does support individuals who do not have health insurance. There are funds for that. But again, disclosing their immigration status to even get to this point can be a barrier to treatment as well. And lastly, I'd like to just say lots of our FSP clients are unhoused. So one day on the referral, somebody might be at the hospital. By the time I get on the phone to call the client, they might already be discharged into the community with no phone or no place to reach them. I think, Stacy, just in terms of time, I could stop there, or if I have more time, happy to continue to jump in.
Well, one of the questions I had though, Susie, is before we go to Karib, is what are some of the solutions that's been proposed to address that?
Absolutely, yeah. So agencies like Momentum help with addressing almost all access to care points discussed above, starting with the outreach and connecting individuals to the behavioral health system. My staff go out into the field, into the community, and meet clients where, you know, an access to a phone call is there, where one-on-one conversations could be had in their own primary language, as well as, again, having available funds for undocumented individuals to access care without needing to have insurance, and funding for community housing to reduce that homelessness for sure. And the last point is that Momentum also has staff that speak the threshold languages such as Spanish to support monolingual clients who otherwise would not have needs to access treatment due to these language barriers.
Awesome. Thank you so much, Susie. I mean, that's very impactful. And I know Karib has some additional feedback or information he can share too, in terms of the services that his program provides. And Karib, so same question to Susie, what are some of the biggest challenges around access to care that you see around clients, around minority clients?
I think for us, it's pretty much the same as far as the funding, historic background also for being African-American. A lot of African-Americans were raised just for actually not being familiar with, care providers and not feeling comfortable going to appointments. So it's one of the biggest barriers, getting them to be comfortable with, hey, this is a health provider, you can talk to them, you can trust them. With me working in a residential facility, we house 45 clients here. So we get a lot of one-on-one time with them. They get a lot of education about the medications they're receiving, their doctor's appointment, their PCPs. And so they're able to kind of get a better understanding of the things that they're getting or receiving or they need. So like I want to go back a little bit about the history. Is back in the day when medicals wasn't available so much, families would take care of their own. African Americans take care of their own. They're in home. You have grandma or mom giving you soup, and you're not really knowing when that kid or your sibling comes up and say, something's wrong. I just don't know exactly what it is, and I think that's really one of the barriers, kind of to describe each individual and how they feel and what they go through, to actually even know that they have a behavioral health issue going on that needs to be addressed. So I think it starts with that history. And as far as us here, to answer your question earlier, Stacey, some of the things we try to do is we educate the client, we sit down with them, and we do have clients when they are ready to leave our program, we actually have them start to administrate their own medication. And that's a big trust level right there, just to go sit with them, have them do their medication. So once they're able to go out in the community, they know what they're taking and what they need to kind of balance their life. So I know Susie took care of a lot of momentum things, so I'm just kind of talking from my program. And I think one of the other things, I also have a criminal justice background also. And there's another, we dealt a lot with incarceration for minorities from all ages, and the lack of medical assistance was kind of tough because they were overwhelmed, understaffed. And now they're out in the communities and they're still trying to figure out where to get that help. So when we say that and you come to Momentum, there's all levels of support here. And I think it starts with the staff here, just communicating and kind of getting an understanding to assess the client and get to know them before, so they can actually trust you in talking about medication and how they feel.
Right. And, Kareem, you raise a good point that, and we'll also you hear that throughout, in terms of and understanding what some of these challenges are, how our staff address that. How do they try and work with clients to kind of help overcome that? So that's a great tie-in too, as we'll be talking about the criminal justice involvement in a bit. So thank you both very much. Celebrity athletes like Simone Biles, Venus Williams, and Naomi Osaka, they stood up for their mental health needs. And although 3 of them are applauded for doing so, they also face, some criticism and backlash, some within their own professions and race. For those folks without the celebrity status, putting mental health first can be even more difficult. So what are some common misperceptions clients may have around mental health, and how can we combat stigma and communicate more effectively? So I'm going to pose this question first to Sarah Morales from our Addictions Treatment Program.
Yeah, thank you, Stacey. I think the biggest thing here is we need to remember that addiction, according to the American Society of Addiction Medicine, is a chronic brain disorder. It is not a moral failing. I think when clients come in for treatment, there's this underlying belief that something is wrong with them. Society has told them that they're not good at making good decisions. They're very selfish. And I think just remembering that this is a disorder that we can recover from. There is a lot of support and treatment out there. I think that will help a lot in sort of fighting the stigma. Just remembering too, I think that when we're working with substance use in particular, we're working with a lot of trauma, and we need to come to clients and families in our community with kind of an open heart and an open mind. I wish we all could receive support like some of our famous folks for our mental health, because it's not fair, right? We know that the more money folks have access to, the better healthcare they may have. And so I think keeping in mind that we need more support for substance use in particular would be very helpful in fighting stigma and making things a little easier, access a little easier for our clients who are struggling. Does that make sense?
And did you have an example?
Yeah, I was thinking about a client of ours that she was 25 years old, so a young adult who came into treatment, identifying in the LGBTQ plus community, felt very much separate, not a part of, experienced quite a bit of trauma before the substance use happened. And then of course, during her active addiction, experienced some trauma after that. And I think the best thing about treating substance use is recognizing that we don't have to do it alone. So helping this person get connected with the LGBTQ plus community, the Ability to Frank Center, really supporting this client and understanding that there's not anything wrong with her. It's not about what's wrong with you. It's about how we can support you and what happened to you. Really helped encourage her recovery. And it was a great thing to kind of be a part of.
And, you know, one of the things that was interesting to note, Sarah, was that, you know, from the APA and SAMHSA, and some of these larger studies is that, you know, the LGBTQ population have a tendency to use more for longer periods of time that's not recognized and it's not actually reported. And so they get underdiagnosed, if that makes sense.
Yeah.
Right. And, you know, it's, if we talk about it, it's like a hidden population. Not everyone visually that you can tell is part of the population, nor do they actually admit that when they go on for services. So that's another thing. And how does Momentum address the needs of LGBTQ? I'm tongue twisted. Yeah.
I think one of the biggest things is we do a lot of training here with the staff, a lot of training on how, this is a quiet population that's gone unnoticed for a long time. And we really want to make this a community where folks feel welcomed, where we talk about difficult topics in a supportive and trauma-informed way. So just making sure that our team is trained to talk about these things.
Awesome, thank you. And now I'm gonna pose the question to Adrienne. You know, Adrienne, and just to reiterate the question, you know, what are some common misconceptions clients may have around mental health, and how can we combat that stigma and communicate more effectively?
Right, thank you, Stacy. So for our clients, I mean, it's being able for providers, for us, for our front desk people, for our peers, for our staff, for our managers or directors or CEO and executives. It's about having an open mind, reserving judgment to support our clients and to listen to where they're coming from. Like my previous colleagues were saying, there's barriers, there's different layers, there's culture, there's criminal justice backgrounds, there's different types of other healthcare concerns that are going on. And it's being able to listen to what's going on, just like these celebrities who had things going on the background that were masked. We couldn't see that from the outside looking in. They had their own traumas, they had their own situations going on, and it's similar for our clients. Our clients come with cultural biases, with criminal justice backgrounds, feeling like they're failures, feeling like they weren't successful. Some of the basic things, just like our celebrity athletes who are human, our clients are human, we're human. And it's important for us to have a purpose. It's important for us to have connections. And, you know, stigma can impact people from just coming to the door, asking for help, picking up that phone and being able to call to the call center to ask for services. Clients can feel that they look like a criminal just because they're getting into services, whether it's criminal justice or mental health, right? I have an example of a client who, you know, since high school, he'd never received treatment. And for him, it was important. He was a Latino. It was important for him to provide for his family, to be strong, to work. And he never was able to do any of that into his 40s because he continued to use, he continued to mask, and going down the line of not being able to provide. Once he was able to ask for help, once he was able to get services, once he was able to understand that what he was going through, other people were going through too. He was able to find his support system. He was able to reconnect with his family. And to this day, super thankful for it, right? Because he was able to reconnect with his family. And even though he continues to have slip-ups from time to time, he knows when he's able to recognize it now, and he's able to prevent it from going deeper and deeper into a spiraling hole. So it's important for us as providers, as people, as advocates, to have an open mind, to have an open heart, and to listen to folks.
And Adrienne, that brings me a question, and I guess I'm going to pose it to you and And Sarah, because, when we talk about folks who have privilege, I mean, sometimes we can have our own privilege. Having a phone where others don't, that's a privilege. I mean, we don't think of it that way. And then there's the intersectionality part. So being a minority, to be in an LGBTQ community, so having multiple identities, right? And not to mention age and religion. Did any of that play a role in either of the clients that you were working with?
Of course. And people have multiple layers, right? And the first part of that is being able to listen, being able to develop that trust, like Harib was saying, for folks to be open, vulnerable enough to share what's going on, whether it's culture, whether it's your sexual identity. It's the ability to be able to be open and not be judgmental, and listen, and being able, I might not have all the resources. It might be the person that can connect you to everything, but if you're able to share with me what your needs are, I can work with you. I can help you navigate. I can help you to learn. We can go to court, then we can go get your diabetes checked. Then we can go to the LGBTQ community centers. And then we can go to the employment and get you a job, and direct things issue by issue. And it takes time. It doesn't all come out once. And it's that trust, being able to build on that and peeling back the layers to be able to be successful and to grow.
And you raise a good point. And before I transition to our next question, Adrian, is that something is culturally, some folks may not know how to put into words. They may feel it may be more physiological than they can verbalize. And that's part of their experience when they come in to get screened and they're working with the clinician, the case manager, and their doctor. And some things evolve over time through trust. They may not tell you at the beginning, they may share that throughout their experience, correct?
Right, learning how to ask for help.
Right. And what we do is, as Sarah mentioned, staff receive education, training, understanding about bias, and things. I'm trying to understand what obstacles exist for certain populations, is being able to really, and maybe proactively, be able to explore some of these things with the clients. Okay, well, thank you both very much. I'm going to now veer into our next question. Mental health and behavioral health conditions are common among people in the criminal justice system, and especially in which BIPOC are disproportionately overrepresented. How has the criminal justice involvement played a part in client outcomes? And for those who were previously incarcerated, what are some attitudes and perceptions you've seen about receiving mental health services for them? And I'd like to kick this off with Diana.
Thank you, Stacy. Good morning, everybody. I actually want to start off by sharing some facts just about incarceration in general. So here we go. Black Americans are incarcerated in state prisons at nearly 5 times the rate of white Americans. Nationally, 1 in 81 Black adults in the US are currently serving time in state prison. In 12 states, more than half of the prison population is Black. Alabama, Georgia, Louisiana, Mississippi, and Virginia, just to name a few. People in jail are 5 times more likely than the general population to have a serious mental health illness. In state prisons, women of all races and ethnicities are more likely than men to have any mental health diagnosis. And last, people with multiple arrests, these are people that are in and out of the system, have shown that they've had a serious health need that needs to be addressed, where they've experienced a serious psychological distress or they're battling substance addiction. For anybody who wants to read more about stats on racial disparities or impacting our jail or prison system, you can look up prisonpolicy.org. I don't work with them. It's not a plugin. It's a nice place to have resources. But what we're seeing locally and nationally is that Black, Hispanics, and Native Americans are being incarcerated at a much higher rate than white Americans. As a behavioral health provider, we're meeting people who've been in and out of the system. It becomes challenging to have a positive outcome when there's so many things working against you. And sometimes it's just the color of your skin. I know I can speak from my own experience just by, walking into the clinic or going into a grocery store. In most cases, when we work with individuals who are involved in the criminal justice system and they're going to court, they already have a rap sheet. So people tend to judge or discriminate against people based on what's written down in their file. So how can you have a successful outcome when you're already being judged? You add the lack of reintegration resources in the mix, and what you get is what we're seeing now, that people tend to not have a successful outcome because they lack housing, like a lot of my colleagues said, a healthy support system, a job because nobody will hire them, or they don't know how to get help when they're feeling overwhelmed. In my personal experience, I've worked with the infamous Judge Manley at the Mental Health Drug Treatment Court in downtown San Jose. I've worked with almost every ethnic background that have been involved in the criminal justice system. Some of the attitudes and perceptions that I see are, I don't trust you. Why should I trust you? Why should I even tell you? You're a part of the system. That's always a good one. And if I told you, you wouldn't understand anyways. So I want to share a client that I actually worked with. I won't use his real name. I'll just call him Robert. But when I first met Robert, he was extremely angry and wanted nothing to do with me and my intake questions. He didn't care what the judge had instructed him to do and what his PO, probation officer, wanted him to do. Robert at the time was in his early 30s, identified as Black, and was living with his girlfriend at the time. So what did I do? I put my intake packet to the side and just sat there and listened to him. That was it. This is what he needed at the time, just someone to express himself with and get the space to kind of do it. We get a lot of people that come into our clinic who are very guarded, have a lot of trauma in their life, maybe managing and dealing with some voices that's happening. And so being able just to be there and just to listen to them is really all that Robert needed. So most people who've been in custody and work with people that they have to in behavioral health, they can read people really well. They want to see that you're being real and authentic with them. I can say that as a BIPOC female minority, it's been easier for me to build rapport with clients as they see the reflection with me. So in terms of proposed solutions, according to the California Department of Corrections and Rehabilitation, drug courts, like the one I worked in, Judge Manley's court, downtown San Jose, within Santa Clara County, they've created jail diversion programs as a way to reduce recidivism. This includes working to provide effective prevention, diversion, and reentry policies and practices that reduce recidivism among individuals with behavioral health challenges. Some other solutions are starting to happen now to address what these issues are doing by what we're doing here, talking openly about the facts and being transparent with what's happening in our community. It takes being vulnerable and putting yourself out there to highlight these problems and creating reforms to change it. Increasing community engagement and actually making things happen versus just talking about it.
Thank you, Diana. And you raise a great point, for the misrepresentation, the disproportionate numbers of minorities that are incarcerated versus other groups. I think the jail diversions are great. And I do know Momentum attends these monthly meetings with the county that they sponsor to kind of address that throughout a continuum of care, do some funding and programs that are currently existing. I'd love to get additional feedback as we talk with Quentin, especially about his experience as well. And Quentin, just to refresh over the question, how has the criminal justice involvement played a role in client outcomes, as far as you know? And for those who were previously incarcerated, what are some of their thoughts and beliefs that you've seen about them receiving services?
Right. So it really just depends. In this field, first and foremost, you can't really hold every circumstance and every situation under like the cookie cutter approach. So some people come out of incarceration, they feel like they're gonna change their life for the better. So with mental health court providing support, they have that reinforcement, they have that structure so that they can become successful in society once again. Other outcomes and situations are different. So clients may become more symptomatic and have symptoms such as auditory hallucinations, delusions, and other symptoms as well, post-incarceration. So that will affect their progress in life as well. So they come out and sometimes they are reincarcerated right when they come out. So it just really depends on the circumstance and how involved that for the support that they have in the mental health system. So those always affect the outcome with certain individuals. Sometimes the perceptions that individuals may face is they may have feelings of they don't want to be vulnerable to certain people, and that they're guarded, kind of like Diana was saying, and they may feel that they don't trust this person. They didn't trust anybody in jail, so how am I going to trust this person providing mental health services to me? So that is a very large barrier within cultural diverse communities, Black, Latino, Latinx. So it just really depends on the support that they have in post-incarceration. Some other perceptions that they have is like, embarrassment. They don't like their conviction, and they don't think that they need to share it with anybody. So that barrier within cultural diverse communities, as well as the effect of those perceptions leading to mental health services. So if clients are more vulnerable, or the more likely they are to get treatment, the less vulnerable. The less vulnerable they are, the more likely they are to not want services, because who wants to share these very tough situations with others. So it could depend across individual to individual. And that obviously affects the staff's relationship. So if they already have this preconceived bias and stigma that these mental health professionals aren't going to hear me out, it's just another person in the system, why do I need to be truthful to them? The less likely they are to be vulnerable to get the treatment that they deserve. And this also reflects on staff as well. So if the more staff approach this and kind of continuously re-engage people in the program and come at them with more of a cognizant approach with their circumstances, the more likely they are to actually engage in that program. So I'd like to share a little story. I had a client a few months back, actually, 26 Latin male that was in gang activity currently and was very guarded and didn't want to share anything with staff naturally. So a lot of the times this happens, you have to develop trust. Very simple. You have to make sure that we provide them with constant re-engagement, reinforcement, and support. And for us as staff, it's important to keep in mind that they don't have to live and be associated with their charge. They don't have to hold identity to if they're an arson or if they're a violent offender or a sexual offender. That doesn't have to be the precedent moving forward. That could be the past, and that could be, just what happened to you. It doesn't have to be something that you hold identity with. So kind of keep on reinforcing with them and encouraging them to, make a change for the future. So with this individual, I had to keep, engaging him. He was very reluctant to let me in. So providing that camaraderie, coming at them with a level of respect and dignity that everyone deserves coming in, mental health services, and not segregate one person over another, and having staff kind of implement that standard is very important. Couldn't emphasize that enough. So with him, having that camaraderie, building that rapport with him, and kind of reestablishing that connection with him so that he can not have this stigma towards mental health professionals was the key to providing success for him. And he came into our program, still using. We had a feeling, because he was a previous client of ours, that he was going to keep using and probably go AWOL, absent without leave. And he ended up, graduating from our program because of the constant support, encouragement from our staff, and, the services that we provided. So that was a big, reinforcement for him, having people that cared and people that he could console with and build that and establish that rapport with. So, and that would develop trust. So he can be vulnerable.
Well, so Quentin, let me pause for a second, because I mean, that's all great information. And I think it really points to, you know, how you create welcoming environments and how folks, you know, on staff help support that. I get a sense too that, you know, when we talk about intersectionality, when we talk about populations, we talk about minorities, we talk about race, we talk about gender, but, you know, criminal justice is one of those marginalized populations as well. And, you know, if they identify as a minority, that's already another element, complexity that they have to deal with. And I want to pose a question, and I need a succinct response in terms of how do you see the use of peers being helpful? So either you or Diana can briefly respond to that. How has the use of peers helped?
I can answer that. Oh, go ahead.
No, go ahead. Sorry.
Okay. I was going to say, you know, we have a peer support navigator here in the adult outpatient program. And I mean, we've seen the impact that it's had already because they have that lived experience. And so they're walking through them and sharing their own experience of, yeah, I've been there. Yeah, I have been using. Yeah, I needed help. I didn't know what to do. And it can be scary. And so being able to come, you know, they can even get a peer support person even before they start treatment. So just picking up the phone, right, is a challenge, is what everybody else was kind of sharing earlier. So what I've seen is that we need more peers, and Santa Clara County is establishing the peer navigator program, where people can walk in to the Zephyr Self-Help Center or to urgent care and get connected with somebody. So, yeah.
Hey, Stacy, also, if I could I just jump in? One of this question on criminal justice is a key question, I think, because you know, I think in our society we've, to a certain extent, we've criminalized these particular behavioral health conditions, and that one of the largest treatments locations and centers is in the criminal justice system. That, you know, I feel like we're at a moment in time where recognition of that problem, that we can't continue to criminalize behavioral health issues, particularly, you know, in communities that have already suffered health disparities, but now that health disparities gap is widening even more during the pandemic. It's important to note that yesterday was the launch of the TRUST program. This is a community mobile response program. It's a pilot program. Momentum has one of the 3 community teams. We're in the North County. Pacific Clinics is operating the other 2 in Gilroy and East San Jose. And this is an effort to provide an alternative to law enforcement responding to behavioral health crisis calls in the community. So as not to engage where one of the outcomes generally of law enforcement responding to a behavioral health crisis call is that someone gets arrested. So we're trying to remove, you know, as best we can, law enforcement so that they can, you know, respond to other calls, criminal calls, actual criminal calls more urgently, and then have these mobile teams out in the community de-escalating and identifying services in the community where folks can go. But again, it takes out that front door of criminalizing behavioral health issues, right? For largely minority communities, communities of color, BIPOC communities. So this is, again, there was a soft launch yesterday in all 3 of those targeted areas. We are very proud that we actually have a team out in North County. But I think it's important to say that entire pilot project was started after George Floyd's murder. And it is, you know, it's come to fruition. So there are things that we can do systematically, right? So these are systematic things. I think the staff talked a lot about individual interactions that we can have. And again, if you have trained staff that are, you target hiring, you target recruitment, you train folks to be able to work with anybody that comes through the door, all races, ethnicities, sexual orientation, gender, age, all. And if they don't, what we're saying now in our employee orientations, we tell them, we'll train you as best we can to be able to work with everybody. If you don't have the will to work with everybody, then Momentum's probably not the place for you to work, to do your professional work. And so again, there are things we can do on an individual basis. We can do things on a service side, but there are things that we have to do systemically across the system. And again, I just want to say how proud I am of our staff, our management team here today talking on this panel, how proud I am of our line staff that are grinding, every day on this. Outpatient residential programs, all. So again, there's stuff we can do, on that one-on-one, work with groups, families, but also we can do in the system. Momentum wants to be an agency in a network of agencies that are anti-racist, that are pro people, all communities, lifting up all BIPOC communities who have historically borne the brunt of, essentially white supremacist policies, institutions, historical that have leveled historical trauma on folks, on communities through the generations. So what you see here today is our effort, right, to put best foot forward, to put best practice forward, and try to heal a lot of that racial trauma and inequity in our behavioral health practice. Again, we are in a network of other agencies that are doing similar. So I don't want to say that Momentum's, unusual, exceptional in its, in that effort to do right by this kind of work. That said, I'm a proud president CEO of a 500-person agency, getting to it every day and trying to represent the other behavioral health agencies that are doing this work right now.
Thank you.
I feel like I want to drop a mic right now. I was on a little bit of a soapbox, sorry.
Well, and David, I feel the virtual mic drop. I mean, that's amazing. I think there you go, folks. And David does highlight, as well as a panel, all of the critical work being done, but also the critical need, because when you talk about combating racism, it's really all of us has to stand up, and it takes a lot more than one organization. We're all doing this together. So with that, I'm monitoring time. I do want to give an opportunity for questions to be posed by participants. And I'm going to ask Alex and Isabel if there are any questions already queued up. And if so, if they can share those, and if not, we'll open it up for questions in the chat based off the remaining time.
We haven't received any questions yet, Stacy.
Okay, thank you. So I would ask this all, if you're in attendance, if you would pose a question in chat, if you have one for the panel, and we will try and respond to that. Otherwise, we'll give that a few minutes, and then I want to kind of give them a chance to do like a brief summary before we close out, if there's no questions. Don't be shy. Please feel free. That's a wonderful thing when everyone's on mute, you don't hear them, but you just wait and see the little bubble. And perhaps as we're waiting for any questions that may come up, let me pose this question to the panelists, and basically all I'm looking to see if you as you think about with the recent protests, as Dave was talking about, George Floyd happened a couple of years ago, but historically some of these things have been happening from a historical perspective. It just became much more visual because COVID kind of made us all be still. You know, as we were in home confinement or whatever we were doing, we saw these things emerge, and it becomes more, we become more aware of it, and especially closer to home. So with these recent protests and demands for a more just and equitable society, there are several actions communities can and should take to bring about sustainable, meaningful change. In your opinion, what are the most critical changes we must make regarding mental health, behavioral health, right? Addictions and mental health, to make sure everyone has access to care they need and deserve. Can you share that in one sentence? And I will start with Kareep.
Thanks, Stacy. I was starting to let it sit in for a minute, but in one sentence, I would just say, change your vision and perspective. I think, like Adrian said earlier, it's all about how you perceive things. And things if your mind state is 20 years old, 15 years old, the world has changed a lot, and we need to look at this behavioral health in a different eyeglass. I appreciate my coworkers because I feel a lot of them do that already. So it's just like spreading the word to people outside of the agency. So I know that wasn't one sentence, but you had me take over.
That's all right. All right, well, and I appreciate you. And, you know, with that spurned some questions. Okay, so let's see. So I'm going to kind of go through, and I see Alex's notes, just so I can kind of pose the questions. What is the best way? This is from Sabri Ramirez. What is the best way to continue the conversation and support each other in our own journeys with race and mental health, so that we feel that we're moving forward and not stagnant? And I just pose this to the panel. So let me repeat it. What is the best way to continue the conversation of outreach to meet people where they're at? Oh, this thing advances. Did I miss it? Okay, the question is gone. What ways can we support individuals? This is from Antoine. What ways can we support individuals who have been wrongly convicted and are involved in the criminal justice system as a result? And I know this is something that may involve resources, but I just pose this if anyone can kind of look at it and address it. So for those folks, how do you support folks who have been wrongly convicted?
Go ahead, Diana.
Well, it's a long answer, so maybe yours is shorter.
I was just going to say, you know, navigating through the legal system in general is tough, right? And then having a mental illness that impacts you from being able to communicate, to being able to get the things that you need, can impact it even more, right? And one of the things that we could do as advocates, as mental health workers, as counselors and ATS, is listen, is being open, being able to listen, and having that person trust you enough to be able to support them in navigating through the system. You know, short story, I had a client who was going through the mental health, through the court system, and it wasn't showing up to court. So first thing I did was, will you let me support you to court? Let's go together. And that was the first time anybody asked them if they could go with them, right? So just as it could be as simple as that. Of course, the resources are challenging, but in order to find those resources with the client, you need to get their buy-in, right? So that trust, building that trust first.
Mm-hmm. And I just wanted to share one additional thing. You know, it's really hard because this happens all the time, but here in San Jose, we have the Mental Health Advocacy Project, where they'll do a 15-minute free consultation with an individual, with the family members, to kind of go over some of that criteria. If you do not disclose that that individual has a mental health impairment, the court system won't even recognize it. So people who've been charged with the crime, the public defender has to receive that information in order for it to get sent over specifically to a mental health drug treatment court. Then it's eligible to have a successful dismissal upon them completing treatment, like coming to momentum.
Thank you, Dinah. And that's great because I think sometimes we don't know. And remember, we have preconceptions, the fact sheet, right? Not the rap sheet. The fact sheet is this is what the documentation says. So therefore, this is what it is. So that just means that's some information, but you get to know the client to understand what their issues and concerns are, right? Okay. I'm monitoring time, and I know we've had a couple more questions. I do want to ask this one, and then I want to get to closing with the panel. If someone has a preconceived bias, so this is from Marilyn Pollard. Hey, great job, Momentum. If someone has preconceived bias towards a person or group with whom they know as a professional in the mental health field and needs help, what are some practical ways to help support that person, to help them be effective?
I would only say from my experience is trying to get to the bottom of why they have a preconceived bias and to not challenge that, but just kind of, you know, gain a little bit more of their perspective into, okay, like we're here to help you with your mental health and there's no conviction that we see right now. We're just here solely to treat you on mental health. And the more we kind of reiterate that and to kind of leave, you know, whatever preconceived bias that they have at, you know, when they get here at the door, we'll say, the more likely we are to help them.
Right. Well, and I think that, and you raise a good point. So there's a preconceived bias clients have coming in. There's a preconceived bias staff or organizations may have. It could be systemic. It could be the person working with them. So really, you know, I think in terms of what has been identified earlier was perhaps some training for staff and understanding what that bias is they may have, the implicit bias. And how do they receive the education and awareness to understand how that affects the work? Because certainly we want to build a healthier community as the goal of any organization. And that kind of starts with building some self-awareness as well, right? I don't think we have enough time to ask another question, but certainly I think, and I'll check with Alex, we can probably respond to it or via email or in some form just so folks can get a response. I did want to take some time, and David, I don't know if you want to say any additional words, because you've been fabulous, all of the panelists, to be able to talk about your experiences, how from an organization, from a systems perspective, what Momentum is trying to do to actually engage and address racism by, you know, making sure we approach things from an anti-racist stance, position, and goals and commitment. David, did you have anything else to close out?
Yeah, I mean, I know we're talking, thank you, Stacey. I know we're talking about race, but I would just say that there are so many isms out right now and such sort of hate to all these different groups and stigma and all. And, you know, again, we want to be an anti-racist. We want to be open to all faiths, all orientations, all gender, all ages, all, you know, people, right? And again, I think when the agency lives out those values, it has its own way of sort of improving the client experience from the inside out. We're hoping actually it includes improving the staff experience inside out, honestly. And so, you know, again, I just want to say I feel like, you know, we're as tough as times are right now, coming out of the pandemic and all the things we've seen, we continue to see the type of hate. We have so many great stories every day of recovery, of folks going above and beyond to try to help somebody. That, you know, I think we're lucky right now. We're fortunate to be a part of this. And so, you know, again, to our board, one of whom actually helped create this week for San José State, Jamal Williams. I just want to say thank you again to our board, our staff, our management team, our direct service staff, our back office staff, for keeping momentum on the, you know, pointing north. So again, thank you, Stacey. Thanks everybody for being on this panel, and thanks for folks showing up today.
Thank you all, and thank you panel. Thank you, David. And again, thank you all, and thank you, Jamal and San Jose State University for hosting us and including us in this event. So thank you. Have a great day.